dive. Today, we're taking a really interesting journey, I think, into the world of psychotropic drugs.
Yeah, we're using some great excerpts from Psychotropic Drugs,
Yeah.
uses and mechanisms as our guide.
Exactly. And our mission for you, listening in, is pretty straightforward. We want you to get a solid handle on these medications.
What they're used for, basically how they work in the brain.
And some of the really key things to keep in mind.
You know, from mood and anxiety management to things like schizophrenia, these drugs are, well, significant.
And how they interact with brain chemistry. It's just fascinating stuff. Okay, let's start unpacking this.
Well, the first thing that jumps out is just the sheer range of conditions these medications can help with.
Right.
Our source material breaks it down pretty neatly. You've got antidepressants first, things like SSRIs, fluoxetine is a common one.
Flunil, I think, is a brand name in India.
That's right, Flunil, and SNRIs like venlafaxine or Venus, mainly for depression, obviously.
Okay.
Then you have your anti-anxiety medications, benzodiazepines like alprazolam, Alprax, yeah, and buspirone too, for schizophrenia, psychosis. That's where antipsychotics come in. Risperidone or Brizando, olanzapine, Oleans, essential stuff.
And mood stabilizers.
Yep, for bipolar disorder, lithium, Literex, and Valproate or Valparin, key players there.
Okay.
And ADHD, stimulants like methylphenidate.
Ritalin,
exactly.
Yeah.
And atomoxetine, Inspiral.
Got it.
And finally, you know, sleep aids for insomnia, Zolpidem, Trazodone, that sort of thing.
That's quite the list. And it's interesting what you said about some being first-line choices.
Yeah, like SSRIs for depression. Often the first go-to, partly because they tend to have fewer of those anticholinergic effects.
We'll definitely circle back to what those are.
Right. And another point, for younger people with ADHD, especially if there's a history of substance abuse, atomoxetine is often preferred over other stimulants.
That's an important distinction. So this is where it gets really interesting for me. How do they actually do what they do, the mechanisms?
Yes, let's dive into that. The mechanisms of action. So SSRIs and SNRIs, they work by stopping the reuptake of serotonin and norepinephrine.
Okay, reuptake, like recycling?
Kind of, yeah.
Yeah.
These are chemical messengers, right? Serotonin and norepinephrine, they regulate mood. After they send their signal, they usually get taken back up. SSRIs and SNRIs basically slow that process down.
Yeah.
So you end up with more of these messengers hanging around in the synapse, that gap between nerve cells.
Which helps stabilize mood.
Exactly. Now, antipsychotics, they mainly target dopamine D2 receptors, particularly in the mesolimbic pathway of the brain.
That's linked to reward and psychosis symptoms.
Precisely. So blocking those receptors helps cut down on things like hallucinations, delusions.
Okay.
And it's worth mentioning, the newer ones, the atypical antipsychotics like quetiapine, they have a lower risk of certain movement side effects.
Why is that?
Well, because they don't just block dopamine receptors, they also block serotonin receptors, specifically 5-HT2A. It creates a slightly different balance.
Ah, okay. So it's like fine-tuning the signals rather than just turning one down.
Something like that, yeah.
What about the anti-anxiety drugs, the benzodiazepines?
Benzos work on GABA, specifically the GABA-A receptor. They make it work better.
GABA is like the brain's brake pedal, right?
Yeah.
Calming things down.
Exactly. When GABA binds, it lets chloride ions into the nerve cell, making it less likely to fire. So you get sedation, less anxiety.
And lithium, you said that was more complex.
It is. Lithium's a mood stabilizer. It affects something called inositol signaling, and it also inhibits an enzyme, GSK3, glycogen synthase kinase 3.
Right.
The end result is it helps level out those extreme highs and lows you see in bipolar disorder.
Okay. And the stimulants for ADHD.
Right. Stimulants, they block the reuptake of dopamine and norepinephrine, a bit like SNRIs, but with a different emphasis maybe.
Leading to more focus, better attention.
Correct. So knowing how powerful these mechanisms are, it does make you wonder about safety, doesn't it? How is it safe to mess with brain chemistry like this?
Yeah, that's exactly what I was thinking. It feels like very fundamental stuff we're tweaking.
It's a good question. Safety really comes down to a few things. First, these drugs are designed to be pretty specific. They target certain receptors.
Okay, targeted.
Second, the effects depend on the dose. It's carefully controlled. And third, and this is crucial, monitoring.
Yeah.
Healthcare professionals watch patients closely.
So it's not a blunt instrument?
Not when used properly, no. It's more like a specific tool, used carefully. Right. And monitoring is absolutely key.
That makes sense. Okay, let's shift gears slightly. How quickly do these actually start working? The onset of action. That waiting period can be tough for people.
Oh, absolutely. And it varies a lot. Like fluoxetine, the antidepressant, usually takes 2 to 4 weeks for the full effect.
Weeks? Wow.
Yeah. Lithium, maybe 5 to 7 days to start kicking in.
A bit faster?
A bit.
Yeah.
Then you have things like risperidone, the antipsychotic. That can start working within maybe 1 to 2 hours.
Okay, that's quicker.
And alprazolam for anxiety, even faster. Maybe 30 to 60 minutes for some relief.
Big difference there.
Huge difference. And then there's how the body handles them pharmacokinetics. Most get broken down in the liver.
By those CYP enzymes?
Exactly, like CYP2D6.
Yeah.
CYP3A4. Key liver enzymes. Then they're mostly eliminated by the kidneys.
But lithium's different.
Lithium's the exception. No liver metabolism, straight out through the kidneys.
And the source mentioned something interesting about fluoxetine's half-life, how long it sticks around.
Yes. Fluoxetine has a long half-life. It stays active for about 4 to 6 days.
And that's actually good sometimes.
It can be, yeah. Especially if someone isn't always, perfectly consistent with taking their medication every single day. Provides a bit of a buffer.
That's a practical benefit. Okay, inevitably we have to talk about the downsides, adverse effects. What should people be aware of?
Right, side effects. They definitely differ. For instance, older antidepressants, the TCAs, they can cause anticholinergic effects.
That term again, dry mouth constipation.
Exactly, because they block acetylcholine. SSRIs and SNRIs usually have less of that.
Okay, what about antipsychotics?
Especially the older ones, like haloperidol.
Yeah.
They can cause EPS, those extrapyramidal symptoms, movement issues.
Like involuntary movements?
Yeah, dystonia, or even tardive dyskinesia, which can be long-term. It's due to blocking those D2 dopamine receptors so strongly.
That sounds really difficult to manage.
It can be, often managed with other meds, anticholinergic sometimes. But it's a big reason the newer atypical antipsychotics were developed lower risk of EPS.
Makes sense.
Then there are metabolic effects. Weight gain is a common one, especially with drugs like olanzapine.
Why does that happen?
It seems related to blocking histamine and maybe 5-HTTC receptors. Lifestyle changes become really important then.
Right.
And then more serious, though less common, is serotonin syndrome. Too much serotonin.
If you combine certain drugs like SSRIs and MAOIs.
Exactly.
Yeah.
Symptoms like high temperature, muscle rigidity, agitation. You stop the drugs immediately, give supportive care, sometimes cyproheptadine.
Okay. And lithium. You mentioned toxicity risk.
Yes, because its effective dose and toxic dose are quite close together. Narrow therapeutic index, we call it.
What does toxicity look like?
Tremors, confusion, kidney issues like nephrogenic diabetes insipidus. Management involves hydration, maybe lowering the dose.
And the source had a specific note about valproate.
Yes. Important clinical pearl. Always check liver function tests, LFTs, and platelet counts before starting valproate.
Good to know. So lots to watch out for. What about situations where you just shouldn't use a drug at all? Absolute contraindications.
Right. Some combinations or conditions are just too risky. Big one. MAO inhibitors with SSRIs or SNRIs. Big risk of serotonin syndrome. Just don't do it.
Okay.
And lithium shouldn't be used if someone has severe kidney disease or heart disease.
Makes sense, given how it's cleared.
Exactly. Then you have relative contraindications used with caution, like benzodiazepines in people with COPD or sleep apnea.
Because they can slow breathing.
Precisely. And valproate during pregnancy is generally avoided. Risk of neural tube defects in the baby.
Okay. What about mixing different meds? Drug interactions.
Critical area. For example, SSRIs plus NSAIDs, like ibuprofen, can increase bleeding risk, affects platelets.
Didn't know that.
Yeah. Carbamazepine can make lithium less effective because it speeds up its removal.
Interesting.
And combining benzodiazepines with opioids, very dangerous. Increases the risk of severe respiratory depression.
That one's well known, thankfully.
It should be. And another key one from the source, fluoxetine inhibits that liver enzyme, CYP2D6.
Right, the traffic jam analogy.
Exactly. It can slow down the breakdown of other drugs using that pathway, like some TCAs, some beta blockers. Their levels can go up.
Definitely something doctors need to track. Let's touch on dosages. Any typical examples?
Sure. Dosages vary a lot, patient to patient. But for example, sertraline, an SSRI, might start at 50 milligrams a day, maybe go up to 200 milligrams max.
Okay.
Lithium, often maybe 300 to 600 milligrams 3 times a day. And again, you'd have to monitor blood levels. That target is 0.6 to 1.2 medi-QL.
Can't stress that enough.
Absolutely not.
Yeah.
Risperidone, maybe start at 2 milligrams a day for schizophrenia, potentially up to 6 milligrams, but again, highly individual.
We mentioned toxicity, but maybe in a bit more detail. Key signs and what to do immediately.
Okay. Lithium toxicity. Watch for tremors, confusion, Seizures in bad cases. Immediate action.
Right.
IV fluids. Severe cases might need hemodialysis to clean the blood.
Right.
Serotonin syndrome.
Yeah.
High-temp muscle clonus. That's like rhythmic twitching agitation. Key is stop the offending drugs now. Supportive care.
And benzos.
Benzodiazepine overdose.
Yeah.
Slowed breathing, maybe coma. Luckily, there's an antidote. Flumazenil. Given intravenously.
Good to know there's a reversal agent for that. Now, the source also flagged black box warnings. Sounds serious.
They are. The most serious warnings. For antidepressants, a critical one is increased risk of suicidal thinking and behavior in kids, teens, and young adults, especially early on or with dose changes.
That's huge.
Absolutely huge. For antipsychotics, there's a warning about increased risk of death in elderly patients who have dementia-related psychosis. And for ADHD stimulants, warnings about potential for dependence and also serious heart problems. These warnings need to be understood by everyone involved.
Definitely. And there was a specific note about clozapine, too.
Yes, clozapine. It's a very effective antipsychotic, but usually reserved for treatment-resistant schizophrenia.
Why reserve?
Because it carries a risk of a dangerous blood disorder called agranulocytosis. Basically, wipes out white blood cells.
Oh, wow.
So anyone on clozapine needs regular blood tests, CBCs, complete blood counts, constant monitoring.
High effectiveness, but high vigilance needed. Okay, as we start to wrap this up, the source gave us a kind of final exam checklist, the absolute must-knows for you listening.
Yeah, let's recap those. First, key mechanisms. SSRIs boost serotonin. Antipsychotics block dopamine D2. Got that?
Got it.
Second, essential monitoring. Lithium levels. CDCs for clozapine. Metabolic checks for atypical antipsychotics. Blood sugar.
Monitoring.
Third, major side effects. Remember EPS with older antipsychotics, weight gain with some atypicals like olanzapine. Fourth, basic toxicity management. Flumazenil for benzo overdose, hydration for lithium toxicity.
The key responses.
And finally, critical interactions. SSRIs plus MAOIs, potential serotonin syndrome. That's a big no-no.
Excellent summary. So there you have it. A pretty deep dive, I think, into psychotropic drugs.